Good morning, everyone, and thank you for coming. It's a pleasure for me to be here today to present my research work. But before I start the presentation, I would like to acknowledge my supervisors and the committee members' contribution to this work. And I also want to thank them for their step-by-step guidance and their patience, because as some of you may know, a few years ago when I started this process here, I could not speak English. So I started by learning English from the language center here at Makerere University. And I also remember the first time I met Professor Nelson, I could not communicate with him, so he called an interpreter to facilitate the communication. So I'm really happy to present my work today. And my research topic is creating and institutionalizing support for evidence-informed decision-making, including rapid response service in the Burkina Faso health system. So this is the kind of outline to guide my presentation. So as a background, since 2001, Burkina Faso Ministry of Health implemented two national health strategic plans, so under which several initiatives has been undertaken and implemented. But some of the knowledge translation initiative that has been implemented collapsed for different reasons, and the rapid response service is one of the units that we implemented with the support with the European Union through a project called SURE. So the units aim to provide evidence to support policymakers with for urgent decision making. And one of the key issues that might sustain the rapid response unit in the Burkina Faso health system is its institutionalization. So in order to institutionalize the service, we did not just look at the service itself. So we decided to learn from existing units to understand how the government usually interact to introduce a new unit in the health system. And also, we also try to understand from existing units how some of the key factors may affect those units' institutionalization. So my research objective is to review decision-making process in Burkina Faso health system and develop strategies to support the rapid response unit's institutionalization, under which I conducted 3 research. And the first one is to understand the policy-making process to introduce a unity in the health system. And the second one is to understand the factors that may affect a unit institutionalization. And the third one, which is about the rapid response unit itself, is to evaluate the process and extent of the rapid response unit's institutionalization. So this is a kind of relationship between the 3 studies. The first study and the second study are, addressing objective 1 and objective 2. So we will learn from information that we'll get from the 2 study will be used to sustain the third study. So I will now start presenting each individual study. So this is about the first study, and has a background. Since 2001, as I said, 2 national health strategic plans has been implemented, and so through which several reforms has been also implemented. And one of the key issues that has been raised during the midterm evaluation in 2005 was issue with some of the health indicators. So the aim for the country was to get the national statistic reports, health statistic report available 3 months after the beginning of the year. but they end up getting it available 6 months later. So it has been an issue for policymakers not being able to get the data to support some of their work. So, and the second issue that has been raised is the health financing mechanism and for the healthcare affordability. So decision had been made to create 2 units to support, to address those issues. And the first unit that has been created is the General Directorate of Health Information and Statistics. And the second one is the Technical Unit to Coordinate Performance-Based Financing. So the study 1 objective is to understand how Burkina Faso Ministry of Health usually interact to create a unit and introduce it in the health system. So we conducted a qualitative multiple case design based on the 2 units, and some of the criteria that guides our this unit selection was that it has to be focused on coordination and management units, and also recent policy that has been implemented, and also we look at legal text that can be used to support and build our case. And the last one is the principal investigator ability to access some of the key players that was playing or discussing to introduce the 2 units in the health system. So we conducted interview and documentary analysis. So the conceptual framework that we've used to analyze the data is the Kingdom agenda setting based on the 3 streams: problem, policies, and politics. So the result, the result will be, for each case study will follow the problem, the policy, and the politics. So the result for this study, for the first case study, which is the General Directorate of Health Information and Statistics. So as I said before, some of the key issue was that there was no regulation in the health system to conduct periodically the data collection for the health system, health information, and also the data collection mechanism was not well integrated, because different units in the health system were collecting the same data and publishing different numbers for the same indicator. So it has been an issue for the policymakers, and there is, as I said, many duplication in the data collection for the same actors in the health system. So as a policy, what has been decided to address the issue was 3 options was proposed. The first one was to keep the health information data collection mechanism under the Directorate of Planning in the health system. And the second option was to create a small technical units under the Directorate of Planning. And the third option that has been proposed was to create a separate unit outside the Directorate of Planning. So as a politics, what has been decided was to create the General Directorate of Health Information Mechanism. So, and what has supported this unit creation was the appointment of a new minister in 2008, who is someone who were really willing to sometimes conduct reforms, not only in the health system, but also when he was a minister in the other department. So he did the same thing. And also, at that period, there was a need for information regulation in the country, not only in the health system, but also under the other ministries. So for the second unit, the problem that has been raised was mainly the budget allocation mechanism. In Burkina, the budget allocation mechanism was what we called the historical budget allocation mechanism, whereby each unit gets his previous year budget increased by a certain percentage. No matter if there is a problem in the unit or not, you still get the same budget line with the same amounts and plus a certain percentage, which is a problem because it's not really, the budget allocation was not based on some of the real problem in the system. So the second problem was the health finance mechanism, under which from different studies it has been shown that household is mainly the first source of funding for the total health expenditure in the health system, and also some of the other issues based on the healthcare affordability being expensive for people, users, with a low quality of care that they are getting. So it has been a problem, so issue need to be addressed. And then as a policy, what has been decided, before this strategy, the country was implementing a strategy called program budget, which is a budget allocation based on the issue. And then the Ministry of Health was a key ministry to implement the policy. Then came this new strategy called performance-based financing that has been proposed by the World Bank. And the country decided to implement the policy based on because they were also planning to implement the new National Health Strategic Plan from 2011 to 2020. So as a politics, there is no legislation change, but in the parliament, through the Health Commission in the parliament, there was a need, a voice raised, to reduce the healthcare affordability to, the cost, and make sure that people can get the care at low cost. As I said, World Bank was the key player to introduce the policy in the country. So, as a discussion, from what we've learned from these two units, was that in Burkina Faso, the decision-making has two channels. The first one is technical, which is a very simple process, and it has been for the technical unit for performance-based financing. It was short because it's a decision that has been signed by the Ministry of Health. And the second unit, which is the General Directorate of Health Information and Statistics, it has been signed through an institutional channel because it has been signed by the President himself, which involves a change in the Ministry of Health organization charts. And also, after the two channels, we also learned that policy-making process involves two phases, an informal and formal phases. So the informal phase is a process whereby donors usually introduce the ideas, and they usually talk to some of the technical units and push the idea forward to the Minister of Health for the decision making. Whereby when there is an agreement that the idea is a good idea that could address some problem in the system, then it's now become something formal, whereby now the Minister of Health will now start interacting with some of the technical unit to, build the case and see how they could implement it. And then, although it's a formal process, there is still, beyond some of the players, some hidden participants who usually make sure that they push the idea forward and sign it so that it can be implemented. So for this study, we had some limitation because we were not able to interview some of the donors because they didn't want to speak on the behalf of the Minister of Health. And some policymakers from where we got some of we collected the data. At the end, they refused for us to transcribe and put it in the reports because of some of the information that they've seen a bit sensitive. And the third limitation that we've seen here is the principal investigator involvement that could introduce some bias because of the way I was guiding interacting with people. But to limit the bias, we two other co-authors reviewed the process, the data coding and the reporting, the analysis to minimize some of the bias that might happen. So this first paper has been published. So now I'll start presenting the result for the second study, which is about the factor that affects unit institutionalization in the health system. So, as a background, over the last year, several initiatives has been undertaken in the system, especially to create new units in the health system. But at the end, some of them did not survive, and they collapse. Sometimes they are in the health system, but really they don't provide any additional support to address some of the key issues in the country. So, and from the discussion that we had with some of the key actors, the first word that usually came to when we discussed with them is that, those units were not really well institutionalized. So the study objective is, to understand the specific factor that usually affects units institutionalization. So it was a qualitative case study based on 2 units. The first unit is the National Health Account Unit, and the second unit is a program called Program for Fighting Non-Communicable Disease. And the criteria to retain these 2 units was that one of them has to be known as well institutionalized, and the second unit known as not being able to be institutionalized in the health system. We conducted interview to collect the data and also did a documentary analysis. The framework that we've used to analyze this study is a framework proposed by the World Bank, under which we have 3 main components here for the institutionalization. The first one being the existence of an institutional framework, and the second is the consistent production of data and preparation of reports. The last component being the adequate resources availability. So under each of the institutionalization components, we've developed some of the some indicators, to do the mapping of the 2 units and see what is the difference and where's the gap. So as a result, looking at each component of the institutionalization process, when we look at the mandate given by the government to implement these 2 units, we've realized that these 2 units they got mandate from the government to exist in the health system. So looking at the home office for them, these 2 units also has office, a place to sit, but for the second unit, which is the program for fighting non-communicable disease, this program is sharing an office with 3 other programs. So it's just one table in one room with 3 other programs. And looking at the protocol to collect data and analyze the data, the first unit is using a framework proposed by the World Bank, the World Health Organization, which is the System of Health Account 2011, and the second unit is using a protocol for that specific disease. So looking at the data gathering, the first unit usually collect data and produce report every year, but the second unit, there is no data collection mechanism, there is no report at all in the health system, and no indicator for that unit in the health system. So now for the third component of the framework, when we look at especially for the resource budget availability, for the first unit there is no state budget for the units, but usually all the activities they are able to implement it through donors funding every year since 2005. Where the second unit has, a budget line available in the state budget, but it's not enough, and the unit has to share it with the 3 other programs, and they are not usually able to implement even one activities in the health system. Looking at the human resources, the first unit has human resources from the Ministry of Health and also technical support from other departments in other ministries. While for the second unit, it's only one person who is implementing the program. And he is not even coming to the Ministry of Health for like 6 months. So what are some of the what are the key facilitators for unit institutionalization? From what we've learned is that policing unit institutionalization depend on the political will to support from state, the government and donors to support the units. And also they usually support the unit based on what the unit is being able to achieve in the health system. So the more what the unit is achieving is important for the health system, and the more they will get support from donors and the governments. So also, another factor that we found is that the unit manager ability to knock doors and sell his activities, talk about his activities, and then raise funds either from donors or from government to implement these activities. So has the government perception on how the policy unit is achieving his purpose in the health system is important to him, then more they are willing to sell those activities and fund the unit with resources and human resources, financial resources and human resources. So some limitation here is that we limited our study on 2 cases, which might be, we thought we could have, learned about more units that's in the health system, but we were not able to do it. We also interviewed a relative small number of people. Some participants were not willing to share the information. Although we've collected the information, they refused us to report it in our report. And specifically for the second unit. And the program for fighting for non-communicable disease is not the real name of the unit. We anonymize it because of the issue that we mentioned earlier. So the second paper has been also published. Now I'll start talking about the third study, which is about the rapid response unit institutionalization. So as a background, several units knowledge translation platform has been introduced in the health system since 2001, and the rapid response unit is one of the knowledge translation platform that has been introduced in 2011 through European Union support, and also through a project called Supporting the Use of Evidence for Health Policy. So the rapid response unit itself, what it is a service, it is a unit that provides services, and the way it works is that we get questions from policymakers ahead of a discussion that they are planning to lead for a decision making. Then we usually go through some of the electronic database, find some of the key evidence, summarize it, and give it to them to support their policy discussion. And then the rapid response unit is a unit that is based at the central level. So the objective of this study is to describe the process and extent of the rapid response unit institutionalization. So it's a qualitative study under which we pilot it and scale it up later, and also we started to implement the process since 2011. And the case study for this paper is the rapid response unit itself. So we also conducted interview with some of the key players and documentary analysis looking at some of the trip reports and available reports in the health system. So to analyze this study, we combined 2 frameworks. The first framework is the framework that has been developed by the World Bank, and it's the one that we use in the second study. And we combine it with a framework that has been developed by a researcher called Rowenzi Mark, based on 5 different phases. So under each of the Rowenzi phases, we decided to map it with the framework that has been proposed by the World Bank. So strategy has been developed under each component of the phases here, and then trying to map them. So as a result, I'm presenting the result based on the World Bank key institutionalization key component here. So looking at the existence of institutional framework, the government practice in the Ministry of Health is that before you introduce a new unit in the health system, it has to be approved by the high-level policymakers. You need to get a decree that need to be signed by policymakers, and also usually they usually establish a technical committee to support the unit implementation. So for the rapid response, we started this process, but we didn't get a formal mandate before we start the process. And the reason being that, one of the project manager was the Minister of Health advisor. So they allow us to start the unit implementation while he was leading the discussion with the policymakers. Looking at the consistent report production elaboration is that, having a policy brief to show, to support, or to help policymakers with their question was important for us. And then keeping the communication with them, because it's a process whereby you have to talk to the policymakers and then make sure that they are able to to keep sending questions. But at the beginning of the process, we were not able to from here. So having the brief was important for us to keep the communication with the policymakers. But then during the pilot phase, even me, it was difficult for me to understand the process. So we came here to learn from the Ugandan Rapid Response Unit, and also we started by translating some of the brief that Ugandan Rapid Response Unit developed and share it with our policymakers. So we started to build, confidence to show them what it is, and then from there we started to recruit people, and among them we started to increase some of the policymakers within the same target group. So looking at resource availability, it's that during each phase of the rapid response unit implementation, we had some different costs that we decided to we mapped from the training, learning the English, and trips, and also being able to get internet connection, equipment for the unit's implementation. So as a discussion, getting the mandate was clearly established during the pilot phase for us, and the decision maker was they were aware from the starting points, so that the units, the brief could support them and be having an add value for them to support their decision making. So expansion for the rapid response service was from the national level to a regional level. So we also started to build our case, recruit some of the policymakers to work with in the same target group. By target group, I mean the director, hospital director, district director, because since when you start providing a brief for one director in the same target group, he will start talking to the other director, and then by curiosity they will come to us and they'll try to understand what it is, and they will start sending questions for us to get the same briefs to support them with the policy making. Also resources being a key issue for the units, especially for internet, and having additional person to work with us was a key issue because of the language issue. Because when we started with people, we trained them. By the time we start working with them and they realize that most of the evidence that we're downloading are in English and they need to read it and understand it, it's become a problem. So, it was difficult for us to keep them working with us in the units. Also, some limitation was that some policymakers that we interviewed were not really aware of the starting point of the units, and also we conducted an interview with a relatively small number of people because it has to be the rapid response unit users, and among them we have to find the relevant people who could understand the whole process from the beginning to the end of the process. So these papers have been also published. So talking about the thesis discussion, I would like to highlight some of the key findings here. So for us, from the 3 studies, institutionalization will require stable environments and mandate from the government, and also enough financial and human resources to implement the units. Second, having a state budget line for our service will be, guarantee the resource availability, but as we've seen from study 2, it might not be enough. Therefore, they need to, keep talking to donors to raise additional resources to support the unit implementation. So, policy-making process in Burkina Faso health system is divided into phases, formal and informal, and also it has 2 channels, a short process and a long process. So policy unit institutionalization depend on manager leadership to raise funds and implement activities, and also the government perception of whether and how the unit is achieving something important for the health system could lead to support from them and donors. Institutionalization process for the rapid response units in Burkina Faso has been fluid, but not linear. Rapid response service has reached the consolidation phase, but not the maturity, which is the last phase of the framework proposed by Lorenzi. The study contribution. In terms of methodology contribution, Kingdom agenda setting model that we've used to do the analysis of the first study is something that could be duplicated for other policy making study in the health system. In paper 3, we combine 2 frameworks to come up with a new framework that could be something useful for someone who would like to conduct a unit institutionalization study. We also used a combined framework from 3 different studies to understand the institutionalization process in the health system. Implication for policy and practice. First, unit implementation, as we said before, depend on the political intention of policymakers to support the ideas and the units. Second, long-term plan should be elaborated at the earlier stage of the unit implementation. And third, the unit objective should be something important in addressing a problem for the health system if you want to get support from the government and donors. And finally, demand for institutionalization should be initiated at the national level by senior level policymakers. So this is the end of my presentation, and I would like to thank you for your attention. Thank you.